If you're a medical student or a junior doctor, you know the adenoidectomy is one of the most common procedures in pediatric ENT. But what if I told you the standard technique you learned might already be, well, obsolete? Today, we're diving into a presentation that is truly practice-changing, one that redefines the standard of care for this fundamental surgery.
Our guide on this journey is a presentation by the brilliant Dr. Ahmed Nofal, professor of otorhinolaryngology and head of the ENT department at Reem Hospital. What his team is doing isn't just a small tweak or an incremental improvement. No, they're setting a completely new benchmark for patient outcomes. So let's get into the data and see exactly why.
So here's our game plan. We're going to start with the basics, the anatomy of the adenoid. Then we'll cover the clinical signs that tell you, hey, surgery might be needed. From there, we'll trace the history of surgical techniques to really understand the problems that needed solving. And that leads us right to the modern, data-driven approach being pioneered at Reem Hospital. And finally, we'll wrap up by looking at what this all means for the future.
First things first, before you can even think about the surgery, you have to understand the anatomy inside and out. So let's establish the why behind this entire clinical discussion. Okay, so what we're talking about here is the nasopharyngeal tonsil, or what everyone calls the adenoid. It's a key part of Waldeyer's ring, which is basically this ring of lymphoid tissue that acts as the immune system's first line of defense. But its location, tucked away at the very back of the nasal cavity, is exactly what makes it such a potential troublemaker.
And this is where the textbook meets reality. On the left, you've got your standard anatomical diagram. But on the right, that's what the surgeon actually sees through an endoscope. This ability to directly see the anatomy in real time, that's probably the single biggest game changer in this entire procedure.
So why is this almost always a pediatric problem? Well, this timeline tells the whole story. The adenoid tissue grows naturally, hitting its peak size right around ages 5 to 7, which is exactly when all those obstructive symptoms tend to pop up. After that, it starts to shrink or involute, and by the time you're an adult, it's pretty much gone.
And this right here, this lateral X-ray shows you the core of the problem, adenoid hypertrophy. You can clearly see that enlarged mass of tissue just crowding out the airway. This is the anatomical root cause for things like chronic mouth breathing and, more seriously, obstructive sleep apnea.
Okay, so we get the anatomy and we get what can go wrong. The next critical question for any clinician is, when do you pull the trigger? When is surgery actually the right call?
Now, it's super important to remember this is not an elective procedure. The number one reason we operate is for significant airway obstruction, like obstructive sleep apnea. We also step in for chronic ear problems, think recurrent infections or that stubborn fluid buildup, which happens when the adenoids block the eustachian tube. And then there are less common, but still important reasons, like chronic inflammation or even impacts on facial growth. All right, we have nailed down the why and the when. Now let's talk about the what and the how. You know, surgery isn't just one static thing, it's an evolving science. And to really appreciate the new approach, we need to look at the historical techniques and understand why a change was so desperately needed.
This is really the central question of Dr. Nofal's entire presentation. For decades, this procedure was done, well, basically by feel. The journey from that blind approach to the modern, visualized precision surgery we have today is just a fantastic story of medical progress.
Meet the classic instrument, the adenoid curette. For years and years, this was the standard of care. The surgeon would pass it through the mouth, up into that hidden space in the nasopharynx, and essentially scrape the adenoid tissue off the back wall, all without being able to see a thing. Just imagine that.
And when you look at the data, the limitations of this blind technique are just glaring. Residual tissue is left behind in up to 40% of cases, which often meant symptoms came right back. Not to mention you had significant blood loss and a very real risk of injuring nearby structures like the opening of the eustachian tube.
So suction diathermy was developed to tackle that bleeding problem, and it worked. It was great for hemostasis, but it created a whole new problem. We're talking high temperatures here, causing significant thermal damage to surrounding tissues, which, you guessed it, led to a lot more postoperative pain.
So you see this history of trade-offs, right? You could have less bleeding but more pain, or a faster procedure but incomplete removal. This whole situation just sets the stage perfectly for the modern solution. So let's look at the how of the technique that changes the entire game: endoscopic coblation. Just look at this table for a second. The numbers really speak for themselves, and the results for endoscopic ablation are absolutely striking. Blood loss, minimal. Right down there with diathermy. The amount of tissue left behind, it plummets to just over 1%. And that postoperative pain score is just dramatically lower.
These numbers aren't just an improvement, they represent a total paradigm shift.
So, how does coblation pull this off? Well, instead of burning tissue, it uses radiofrequency energy to create this super-focused plasma field. And the key is, this field operates at a really low temperature, basically dissolving tissue at a molecular level with almost no damage to the surrounding areas. It's controlled, it's precise, and it's just a much, much gentler way to do things.
Now, cool technology is one thing, but the real test is how it performs in the clinic, right? So now, let's look at the proof, the hard evidence from Dr. Nofal and his team at Reem Hospital, who have used this technology to set an entirely new standard of care.
And this new standard isn't built on anecdotes. It's built on rigorous research. Here's the abstract from Dr. Nofal's 2024 study, where his team actually went in with an endoscope and looked at patients after they had a conventional curettage. They systematically documented the high rates of leftover tissue and injury, providing the hard evidence that a better method wasn't just a nice idea, it was a necessity.
This side-by-side comparison, it says it all. On the left, that's what's left after a traditional curettage. A big chunk of adenoid tissue still there. And on the right, that's the result after an endoscopic coblation procedure at Reem's Hospital. A completely clear, clean nasopharynx. The visual evidence is just undeniable.
The clinical results are just as stunning. Out of 1,000 cases performed using this technique, there have been only 2 symptomatic recurrences. 2. That's a recurrence rate of 0.2%. It's an incredible testament to the precision of this procedure.
So to wrap up the benefits here, with complete endoscopic visualization, surgeons can actually see and avoid injuring nearby structures. The low-temp coblation means less pain and a faster recovery for the kids. And because it's so precise, surgeons can preserve critical structures like the velopharyngeal valve and even perform the procedure safely in complex cases like a submucous cleft palate, which used to be an absolute no-go.
Wow, okay, so we've seen the problem, we've walked through the old solutions and all their flaws, and now we've seen the data-proven modern approach. Let's bring it all home with the key takeaways and what this really means for the future of pediatric ENT.
The evidence that Dr. Nofal presented is just overwhelmingly compelling. The endoscopic coblation technique is superior across every single metric that matters: completeness of removal, safety, bleeding, and postoperative pain. And that leaves us with one final and really crucial question. It's no longer about if this is a better technique. The question now is, what are the next steps in training, in accessibility, and in policy to make this safer, more effective procedure the universal standard of care for every single child who needs it?